This is going to be, I'm going to be taking you to like the 1,000-foot or 50,000-foot level. So I hope I'm going to just entreat those of you that are really on the front line, you know, right there taking care of patients day in and day out, to sort of come with me to inside the Beltway. Of course, my other thing is to say, hi, I'm here from the federal government and I'm here to help you, you know. But yeah, right, I know, don't throw things. Eat your lunch, don't throw things at me. But come with me to sort of, you know, put your hat on that takes you inside the Beltway, to be thinking about healthcare across the country. All right, now let me get this thing. I got to come over here so I don't like fall off this podium. I'm basically going to talk a little bit about what's the need for value and accountability, and transparency is embedded in that. But I'm going to zip through that because we all experience healthcare one way or the other, and we all know that we have a need for that. I'm going to talk a little bit about where we are now, what evidence can inform us in terms of some of these things that we've been talking about this morning, sort of where the current momentum is nationally, and where I think things are sort of headed, and along with some of the challenges faced. Now, I'm going to be talking very, very broadly, so I want you to think a little bit about how MRSA might be one topic that we could have as that we focus on as I talk through a lot of what's going on nationally and within communities. Okay. You're all familiar with the paradox of American healthcare. I'm preaching to the choir. We've got great things. We make miracles. We save lives constantly. And at the same time, it's very hard to get people to be able to say that they got the right care every time, and every patient got the right care and not any extra care every time. So there really are serious and systemic quality and patient safety problems in this country. I would also submit that we've got lots of data that tells us that we're spending way too much for healthcare given the outcomes that we're getting. So our percentage of GDP is much higher than the other developed countries, and in fact, when you compare us in all of these international comparisons, we rank the worst. So if you'll look at, this is from the Commonwealth Fund, you know, Austria, Canada, Germany, New Zealand, the UK, we're pretty bad in most of this stuff. Now, we are ranked number one in right care, but I'm sorry, I'm not sure we can say that that's worth $6,000 per patient compared to $2,000 and $3,000 per patient, and that was 2004. It's only gone up. And if you think that this is a sort of a fluke, 3 years running, every time Commonwealth does a survey, we come out on the bottom again. So I would just submit that we've got some serious problems. Now, the data also shows that we've got variation across the state. And of course, Kevin's got his website with 45th in the United States. I think that's admirable of you but I wasn't quite sure initially whether you were celebrating that or not. But you know. But there is variability, and I would also submit, those of you that are in the measurement world, you know, there's variability among and between the states. There's variability within hospitals. I have yet to see, I've spent a lot of time in my life doing measurement and quality improvement, and I have yet to see a bad hospital compared to a good hospital. I find hospitals that are good in some things and have opportunities for improvement in other things, and the same with the hospital down the street. So it really, I really have not in my years of measurement and feeding back information to hospitals and healthcare systems, or physician practices for that matter, seen sort of the bad ones versus the good ones. It's really variable within healthcare systems as well, which means we all have opportunities to improve. Now, I'm going to try and have you put your hats on in ways that are not as providers. So I think there are at least a couple of you here that wear those other hats. I happen to know some of the folks here. But right now I'm going to suggest that the purchasers of healthcare are really freaking out. I mean, think about the auto industry. And you know, I'm sure that you've heard some of the stories about how, you know, the cars at GM cost $1,000 more because of having to pay for health care benefits, which is sort of why they negotiated the whole thing over into the union. And now the union is bearing the risk of the health care for all those retirees, et cetera. But of course, maybe it was a good thing, since GM was like, we're close to having all of our auto industries go out of business. Anyway, the purchasers are described by my almost disappeared boss, Secretary Levitt, as having their hair on fire. And I think that's an apt description. They're really upset about the amount of money that it costs to pay, that they're paying out for health care. And they're also really surprised. They've been doing things like Deming's Florida Power and Light, you know, model, lean GM's lean, Toyota's lean process. They've been doing systematic quality improvement for several decades now, and they can't figure out why healthcare hasn't incorporated those manufacturing techniques into their quality improvement initiatives. Now, I know that that's growing, but we've been behind some of these other industries. And then they're really, when you say, well, we really want to do a good job, we just need to have some seed money to be able to do better quality, they're like, heck no, you know, I mean, they're really skeptical about paying more for providers to improve quality of care. Well, what about the hospital? It's not like providers are, you know, I would say providers are not like Wall Street CEOs. I don't know a lot of hospitals that have incredible, you know, margins. They're really worried about the reimbursement that they're getting. They're concerned about workforce shortages, and maybe there isn't a nursing shortage. Maybe there's not a nursing shortage of bodies, but I would submit that there's still a distribution problem that we have with healthcare professionals. But in any case, there's also concerns. They've got concerns about their emergency rooms. They're concerned about all the public reporting and the burden of collecting measures. It's like, how many more nurses do you have to hire to collect measures to be able to do this public reporting? So there's a lot of concern about things. I'm not citing, but you can see this comes from a 2007 AHA survey of hospital leaders. And I can get you, the references for all this stuff are on the slides, and I can get you the slides if you want them. Physicians are, you know, I'm a general internist by training. And, I have to say I'm also a baccalaureate degree nurse. So that I thought, right. And actually, I think that it may have even said RN, but I'm not an RN because I let go of my license when I had to start paying for my medical license. But my college degree is a BSN. So anyway, and I practiced for 6 years. So that allows me to yell at both you know, clinician groups. You know, I can sometimes step out of one role and into the other. Anyway. And I will say that there's nobody lower on the totem pole than either a nurse's aide or a student nurse. I actually think student nurse is worse than nurse's aide, you know, in terms of the jobs over the years that I've had. But be that as it may, physicians are really struggling with they are overwhelmed with the paperwork, and again, the loss of control, some of these issues about accountability. They're also very frustrated about malpractice and what they have to pay, and the need to practice defensive medicine. Consumers. The studies have shown that at least 75 to 80% of consumers think that we need a major overhaul of healthcare, that we can't just be tweaking it, that we have to have reform. And there's growing concern about the amount of money that you have to pay out of pocket for your healthcare. I would say that the other interesting thing, though, is that there's confusion about the biggest drivers of spending. Consumers in this particular study really thought that the biggest drivers were the pharmaceutical company CEO salaries. And although pharmaceutical, I am not here for, pharmaceutical company CEOs may make too much money. I mean, I'm willing to go there with you, that's fine. It's actually, there are several economists like Uwe Reinhardt and others who will have done the analysis and say that it's the demand for new technology on the part of the patient, on the part of the consumer, the latest test, the assurance of a test, where we don't really even have evidence to support that the efficacy of this new test is better than the old test. So really that's one of the biggest drivers. Uwe Reinhardt would also say that the cost of malpractice insurance and that's the second biggest driver. Anyway, this is also a group that wants major reform. Okay, so where does this leave us? Lots of reports documenting that we got a substantial gap between where we want to be with quality of health care and where we are. Increasing demands from purchasers, proliferating disparate pay-for-performance initiatives. Because their hair's on fire, the employers and the purchasers are already kind of driving this external sort of attempt to lower costs and at least not decrease quality. There's a lot of measures going on. There's a lot of measurement, development, and collection burden. I mean, you just even have to look at CMS and see all the stuff that's coming out of there, and that's just one group. Really, there's a ton of proliferation of measures. And then there's this. We do have some bright spots. There is a demonstration that I have some more data to show you about public reporting of performance, leading to some improvements. And there is a recognition that measures ultimately are going to require efficient data capture. I am so happy that in the past, I would say 5 years, we're slowly shifting from we have to get all these claims-based measures set up to, okay, the claims-based measurement system is a step toward real-time information captured electronically and able and to be used for quality improvement. So I think we're making progress. I threw this in just because it was sort of fun I actually did this for a different talk, a brief U.S. history for quality healthcare. It certainly doesn't cover the landscape, but it's not like we haven't been trying to improve healthcare for ever. I started with 1910 and Dr. Codman, calling for quality improvement and outcomes for effective care. And if you sort of glance through here, you'll see the Joint Commission being set up, so accreditation, accountability to an external entity. We've got the Social Security Act that makes conditions of participation part of getting Medicare payment. So we've got legislation. We have some of the work, the theoretical work of Donna Bedian with structure, process, and outcome that still really, really drives us, I think, and is a supportive framework. And we've got the IOM most recently. We have less legislation and more IOM producing reports saying, we got to really improve. So, to err as human hit the stands and made a big splash and really started to mobilize the patient safety movement. We've got the crossing the chasm. And then because I'm from HHS, I had to stick on there as the last one on my list, the Health and Human Services Value-Driven Healthcare Initiative, which is what I am going to talk to you about more. So, there's just one little plug for where we fit in. I'm not quite so grandiose as to think that between 1910 and 2006 that these are the only, and that we even do fit here yet. I'm not sure we do, but that these are the only salient and critically necessary things that have happened. Okay, approaches to improve quality. Again, this is very broad-based, and I only have 2 slides. One is what I'm going to focus on is not to say that all these other things aren't important. Within the delivery system of healthcare, you got to be focusing on people, leadership, culture, et cetera. There's got to be a focus on information management. You got to be doing the process improvements. You've got to be working on patient activation. I mean, these are all methods that exist and within the framework of healthcare reform are important. But there's also this beyond the delivery system. So accreditation and professional accountability, which is, by the way, the professional accountability is has been the primary focus for many, many years. So that means I get my license, either as a nurse or as a doc. Board certification. I mean, these are all professional accountability kind of models of improving the quality, assuring the quality and value of healthcare. Legislation, as I mentioned. Increasing information availability. Transparency is the one that we're really focusing on more today and is really on the upsurge. And behavior shaping. I mean, Skinner was a long time ago, but behavior mod's been around a long time. And as one of our previous speakers said, incentives do work. Now, there's a lot of caveats about incentives working because you have to have the right incentive, it has to be a strong enough incentive, it has to overpower the disincentives. I mean, there's more to it than meets the eye. But behavior shaping does work. And consensus building for voluntary action. I'm going to sort of focus a little bit more on that. You know, I'm going to be the one today that says, we're all in it together, can't we all work together? Okay, what do we know about public reporting? The evidence is mixed. We do know that it stimulates hospital quality improvement work and activities. So that we know. We're not so sure about whether it actually improves patient outcomes. There's literature that shows that it does. There's literature that shows that it doesn't. I think that we're in the infancy stages of knowing what public reporting does, and it's because we are not refined with figuring out what to report and when to report it to whom and in what manner to report it. And we have a lot of work to do to get beyond the infancy stage, but that it shows promise. It's got an inconsistent effect on hospital and or practitioner selection, and it has a modest association with plan selection. Again, I'm not going to go into details, but if you as a community decided that you wanted to tackle MSRA, I would suggest that I'm going to lobby here now, and obviously I work for the federal government, so I don't get paid. I would lobby you to go to the AHRQ website and start pulling out tools that we have for free on what are the best practices in public reporting for consumers. You know, consumer guides for decision making. I mean, we have a ton of tools that are evidence-based approaches that can help you in your efforts. And we also found that it had modest association with plan selection. This is from a Annals of Internal Medicine article published January of 2008. Tiered physician networks. Okay, this is a blurb that's to have me sort of remind you of something, and it's kind of convoluted. I know it looks convoluted. Minorities distributed evenly among specialists, regardless of designation as efficient or not. It's like, what the heck is she saying? Well, there's been a whole lot of pushback about putting doctors or hospitals into these preferred tiers based on whether they meet some quality standard and also are efficient. And there was I think it's Casalino and et al. Started to publish things that basically said, my patients are sicker. Therefore, you can't punish me by putting me in not giving me the star. If you don't give me the star that I'm efficient, it's because my patients are sicker. And we've all heard that, you know. I mean, I'm a doc. We've all heard that in the measurement world. You feed back the information to the physicians, and the first thing that they say is the data's not accurate, and the second thing that they say is my patients are sicker. Well, that's being pushed as far as this feedback around these tiered networks of providers and hospitals as well. And what Troy Brennan did in a study that was recently published showed that, and the other caveat to this is, my patients are sicker because I see more minorities and quote unquote, we all know, and this is not me speaking, this is this argument being made. We all know minorities are not compliant, therefore that's why they're more sick, okay? That's why I'm not efficient, because my patients are minorities, I see more minorities, and minorities are not compliant with healthcare. So these are stereotypes that have been emerging in the literature. So Troy Brennan did this analysis, looking at the data, and showed that it's not true. that whether you're efficient or you're not efficient, you were seeing essentially equal numbers of minorities. So at least blaming it on the minorities as being your sicker patients wasn't accurate. So I just wanted to explain it because it's so convoluted. Okay, what we think we know about pay for performance. There's a study that we have on our website that's also a JAMA article that talks about these being the critical design elements for a pay for performance initiative. It's deciding on individual versus group. It's paying the right amount. These are some of the things that I was alluding to. Selecting high impact performance measures. You know, if you have a pay for performance system in place, but it's some obscure measure that has nothing to do with what the person spends 80% of their time doing, it isn't going to affect them. You know, you really have to use common sense when you set up these programs. And then again, having payments reward all high-quality care as well as improvement. I need to add that. I think we all know that at this point that if you just pay the people that already are doing the high-quality care, you don't make any change because they would have done it anyway, and all the people that need to improve aren't improving because they're not getting the reward to improve. So you need to pay improvement as well as high quality. And I think everybody understands that what's really, really critical is this issue of measures. Measures, reliable, valid, standardized performance metrics, critical for apple-to-apple comparisons. And I know that each of those words are loaded. All right, so what's value-driven healthcare? Secretary Leavitt was just really, really forward-thinking and came up with this initiative where he really wanted to get us thinking about standardizing performance metrics across the country. And that would be metrics for quality, metrics for price. It would be so that we could increase the information that we were all sharing with each other, and that it would be adequate information that could be used to incentivize appropriately high quality, low cost, i.e. value healthcare. The principles are all healthcare is local, that everybody needs to work together, that this broad access, the market having broad access, transparent information that's meaningful, accurate, would allow everyone to be equalized in terms of the playing field. Providers would have information that was designed and fed back to them in an aggregated fashion such that they could improve their practices, that the consumers could really, it would improve consumer decision making about providers, and I think more importantly about treatments, and then that it would also be used to inform public policies and payment policies that again foster and reward the value of healthcare. So it's really about getting standardized performance metrics. So what do I mean by that? I mean, we all agree to define hemoglobin A1C for diabetics the same way. We all agree that if we're going to measure diabetes, these are the measures, and this is how we're going to define it. These are the exclusions, these are the inclusions, it's for this population, you know, this age group, blah, blah, blah. It doesn't mean standards like, oh, this is the definition of high quality. It really just means, could we at least all measure it in the same way so you can make apple-to-apple comparisons? How do we get there? Our theory of what is needed for healthcare reform is that we've got to get national coalitions, national alliances to build consensus on standards and measures, and that multi-stakeholder community collaboratives are really where the action is, and that they've got to facilitate and manage ongoing effective local stakeholder relationships and coordinate the implementation of local activities. So, for example, the Public Health Collaborative I was checking it off. I was saying, okay, well, it's got providers, it's got the Department of Health, I didn't see health plans there. I wasn't sure if I saw employers there, but with a little bit of addition, it could be a chartered value exchange, which is what I'm going to be, a community coalition designated by HHS. So some of these national healthcare alliances, I'm not going to go through these. It's actually a salad of acronyms, and I think it's hysterical. And of course, we almost have too many already, but they are actually trying to align. I'm going to show you. I have a slide at the end that I'm hoping you'll like. So you guys know of these, right? NQF, AHIC, HQA, AQA, HQA, AQA, steering committee, and numerous work groups. I mean, they're all They're all doing stuff inside the Beltway. Okay, I admit it. And I have some slides that define sort of a little bit more, but this, like HQA, this is where hospital compare came from. Okay, so it's not like if you're in the front line, you're not impacted, because that's how that got started. The HCAP's now getting public posting, the Patient Experience of Care. That's coming out of the Hospital Quality Alliance. AQA is the Ambulatory Quality Alliance. Oh, and I talk even faster because it's like already 1:30 and I'm supposed to be done. The funny thing about AQA is that it was supposed to be just ambulatory care docs, and the docs and it was multi-stakeholder, you can see, well, the Society for Neurosurgery, came to the meeting and they got really mad and said, we want to be at the table, we want to be at the table. And we were like, well, but you aren't doing neurosurgery in the ambulatory world yet, are you? I mean, I know we've got these ambulatory surgery centers, but this is like getting really crazy here. And they said, no, but this is where the voice of the physicians really heard. So now all the medical societies are like, at the table, working on these issues, really focused on, one of the big issues that's being focused on are these episodes of care. Again, something that you're going to hear more and more about. But I just had to laugh about the fact that, you just never know what the untoward sort of reactions are going to be to some of these things that you form. But okay, fine. It's good. More people, the better. The Quality Alliance Steering Committee came about because we realized that we had 3 different ways of measuring diabetes. We had 3 different ways. We had the inpatient, the outpatient, and the long-term care. So it was sort of like, okay, can we get together and harmonize these measures? And can we figure out how to make measures go, across settings in the future so we don't have to do the retroactive fitting? And all of you any of you that work in hospitals know the painful years of negotiating between Joint Commission and CMS to get the cardiac measures to agree. So this was a group that was set up for a number of reasons. One of the first was to try to figure out how do we get to a process where our measures can work across settings and we have a single type of measure. Again, how do we get there? I've talked about the national alliances very rapidly. I'm going to talk a little bit about these multi-stakeholder community collaboratives, which is part of one of the main things that I do in my job. So we call them chartered value exchanges. With the change in administration, we may start calling them community value exchanges. They're really to maintain the stakeholder engagement. It's really to keep the folks at the table. That is one of the primary jobs, and it sounds easy and it takes a lot. It is not easy to have people who typically are against each other, adverse with each other. The health plan and the hospitals, or the hospitals and the purchaser, or, the employer. Or it's not easy to have these people actually sit and talk and hold the conflict. Any of you that know anything about relationship management, one of the definitions of a strong, healthy relationship is that not that you have no conflict, it's that you can hold the conflict, you can talk through the conflict and still move forward. Well, that's what one of these chartered value exchanges' primary roles is, and I would encourage you as a community to sign up to be one. Okay, the more practical things that they do in addition to this relationship management is figuring out how to get or make this performance information that then doles it out, basically. Maybe your QIO takes the lead on provider improvement. Maybe your consumer union group, your consumer reports people take the lead on figuring out how to do public reporting. And maybe your employer group decides how they can set up incentives for consumers and for the providers in order to facilitate incentivizing for improved value. And I really don't want to forget the health information exchange and health information technology folks, because if there is a RIO in your area, I mean, it's a good idea, or a state data organization, it's a good idea to have these folks engaged and working on this transition from claims-based performance measurement to real-time decision-making fed back to providers. Benefits. The benefit is that you get an HHS designation, which is just a little plaque, and but basically that you join with AHRQ in a learning network where we provide technical assistance to you in small groups, individually. We take the feedback that the value exchanges give us to then fund grantees to develop products that are needed, real-time products that communities need. And it's also, we've set it up so that the chartered value exchanges are feeding into all those national alliances, because, you know, if you've got national alliances and everybody's from inside the Beltway, we can come up with a whole new reality that has nothing to do with what's going on in the front line. And so it's really critical that the front line have a feedback loop with these national alliances, be sitting right at the table at the national alliances saying, this is what makes sense, these are the innovations, these are the best practices, this is what needs to, and these are the needs that we have from you as these national alliance consensus building entities. Here are the chartered value exchanges we have right now. There's 24 of them. One is the Greater Louisville Value Exchange. Before I came, I checked to see if maybe you guys could join with them. James has a brochure on them. And what I heard was, no, Lexington and Louisville are two different worlds. And so that's okay. I will tell you that I took flack for this, but I insisted that I could not define a community, that you had to define a community. And some of the community value exchanges that we have are statewide, and we have three in Michigan, because they're different communities. They're just completely disparate kind of communities. You have to define the community because you got to figure out how to work together. Issues: coordination of methods and performance results, obtaining timely data, migration of measure calculation, dimensions on which to standardize. What do we do around the country? Should we all have the same report cards or not? I mean, we're doing that with some things, but perhaps not with others. And again, dimensions on which to cooperate versus compete. My previous boss, Tom Smith, who was the CEO of the Voluntary Hospitals of America, was just so great. When I joined that organization, I had just left the VA setting up their patient safety program, and so now I wanted the private sector to be able to like take the lead on patient safety, you know, because I'd changed hats, you know, and so we wanted to do this big conference, and some of the Premier people, you know, we wanted to do it with the Premier, which is the other big group purchasing agency. And the people around me said, oh, no, we compete. No, oh no, you can't do anything with Premier. They're our arch rival. And, you know, I was kind of dumb and I was new. And so I kind of just started, you know, I said, well, what do you think about that? You know, and Tom, what do you think? And he said, we compete on execution, not on information. If there's any piece of information out there that could save a patient's life, we need to share it. And that was all I needed. So Premier and VHA co-sponsored conferences. We developed sharing of information activities. And I would challenge you that transparency is about sharing information, and that you can share a lot of information even with those with whom you compete. You just need to figure out what to compete on and what not to compete on. And in fact, the chief medical officer for Premier, you know, and I got on the phone. It was so funny, and it was Jack Cox at the time, and Jack and I said, okay, well, here's a list of 10 things. Okay, we're going to compete on these. Okay, yeah. So we won't talk about this. Okay, but we're going to work together on these. Okay, yeah, all right. And we just did it explicitly. I would suggest to you that although I'm not always emotionally mature, that was a moment of relationship maturity where we were able to explicitly discuss our differences and hold the conflict and move forward. I'm seeing some nods. Thank you. You know, there are moments when I am. All right, now there's also a plethora of initiatives, and I know that you guys get bombarded with all that stuff. But I'm going to suggest to you that this is all beginning to fit into the circle of hope. And I'm going to end with this. And I did have somebody make a crack at one of my speeches where they said, well, it looks like the circle of confusion to me. Some days we call it the circle of love, the circle of life. It sort of depends on, you know, how you're feeling that day. You're not expected to read this, but what I am going to suggest is that it starts at the top, sort of at 1 o'clock, with the NQF National Priorities Partners. And that's everybody, that's the usual suspects. But it's trying to say, what are the priorities for quality improvement that our country needs to address? And so let's start there. Let's figure out where we're trying to go. What are the goals that we have? Then let's figure out who's doing measurement. It's really a circle of who's doing what. Some of it's aspirational, some of it's the current reality. But it's trying to get control of who's doing what in this space, and how do we begin to migrate to a more and more efficient, consolidated approach at the national level, such that we are not driving everybody crazy that has frontline responsibility for reacting to all this stuff. And so it just sort of maps out. And I don't have a pointer, but this is sort of measured development. This is implementing things. It's figuring out who's actually making change within the community. So here's where my community value exchanges are, getting the data pulled together, figuring out about public reporting, figuring out about policies, payment strategies, really working on quality improvement within the hospital system and beyond, and then constantly sort of evaluating, does this make sense? Are we actually getting to better consumer outcomes? Are we really getting to higher quality, equitable, cost-effective, patient-centered care? So it's really sort of an attempt to begin to get our act together on the national scene and in conjunction with local communities.